management. Prof. Rida, please. Do you have a recording session or yes? Please, Dr. Bayu.
Assalamualaikum warahmatullahi wabarakatuh. I am Professor Rida Dharmajaya. So today we will talk about current trend of pituitary tumor in our hospital in Haji Arimuddin Hospital Medan, overview and surgical management. As we know, the pituitary is an endocrine gland that's located immediately below the base of the brain, and it produces hormones that impact numerous parts of the body and stimulates all the other endocrine glands to produce their own hormones as a master gland. Pituitary adenomas account for about 10 to 15% of all intracranial tumor. This is how we divide the adenoma, or functional and non-functional adenoma. The functioning adenomas are classified by the hormones they secrete. Functioning tumors may secrete prolactin, growth hormone, FSH, and LH or TSH. And what we can do with this kind of tumor, we can provide operation to save the patient. For non-functional, we should think whether the tumors do not cause clinical hormone hypersecretion, so it do not cause hypersecretory syndromes, but we will think about the mass effect. Is it already make the mass effect, so it will grows that make compression with another surrounding area. So if it is happen like that, we will prefer perform surgery. Otherwise, we will do the medical treatment. This is in hypothalamic region. We know that it's not only pituitary adenomas, could be craniopharyngiomas, rectus cleftis angiomas, or prolactinomas. That's the most common. And we will think medical is one of the things can do, but if it is already make the mass effect symptoms, so surgery is the best choice. And we can think how we make a team with multidisciplinary team with our colleague in another medical field like endocrinologists or pediatric endocrinologists, and we can choose which is the best corridor to come to take the tumor, whether microscopic or endoscopic. So it's influence its approach that we have to do. What we need to achieve is early detection of tumor. That's part of the things that we want to know, and we should establish the diagnosis and which is the most suitable treatment that we can do. Removing pituitary mass while preserving the normal pituitary tissue and by structure surgically, or we can choose treatments alone or concomitantly must eliminate hormonal hypersecretion or its effects, prevention tumor recurrence, recognizing and caring for acute and delayed complication of the disease. This is the clinical sign that could be happening. Of course, if it is because of the compression of the adjacent normal gland, you can think like what we always find is for the visual disturbance. As we know, if is compressed nerve, we can find the clinical sign is hemianopsia bitemporal, pretemporal hemianopsia, or if the tumor is already quite big, it could make blind in one side, the eye visual. And hormonal hypersecretion, it depends which hormonal it's effect, and headache cause. Usually it's because of the tumor is quite big, and it could compress the CSF, or it will make hydrocephalus, and it will make the symptoms of headache. This is what I wrote just now about bitemporal hemianopsia, and hormonal sign is like acromegaly. We can compare the finger of the patient with the normal people, and we can make a laboratory workup. 60% of adenoma secretes and T hormone. It will measure pituitary and tumor function is needed, and it include serum levels of prolactin, TSH, LH, FSH, growth hormone, IGF-1, IGF-1, T3, T4, cortisol, ACTH, estradiol. It could make systemic imaging modalities to confirm the diagnosis and determining the differential diagnosis of other cellular regions tumor. You can find it first from the X-ray, especially the cellular X-ray. We can look for the cellular. Is it have kind like ballooning cellular, and we can find it of course in CT scan and head MRI with contrast. This is the ballooning cell. Find it something like this, and we can make a line here. It's a imaginary line as a diaphragm cellular line that we imagine. This is a cellular region tumor, but actually with this kind of looks is like craniopharyngiomas, and we can see the cellular. There's not so big cellular, so it's not ballooning cellular here, but the tumor is already big up the side, and it's different with here. We here see this is the kind of macroadenoma, and we will see the cellular floor is bigger. Even the tumor is not as big as the craniopharyngoma at this part. This is cleft cyst, and this is the meningioma here. As a surgical management, we can find some approach to do, but the goals are to achieve gross total removal whenever possible, and of course we have to reduce ICP if it is happen, such as hydrocephalus, that quite big tumor that compress the passage of the CSF, and to relieve neurological and endocrine manifestation, and to preserve normal pituitary anatomy. Pituitary surgery, most effective procedure for acromegaly, scaling disease, etc., and also effective for pituitary apoplexy, rare cases of pituitary cancer, and we can do it in emergency fashion, and recommended for cellular pathologies. We can do with endonasal, transcranial, and transcranial. Transcranial approach, significant morbidity and mortality, consider age, current health condition, visual function, and we have to know the characteristic from the imaging that we have from the tumor extending superlaterally to the supracoroidal carotid artery, reaching foramen Monro or encasing subarachnoid arteries, tumor with asymmetric subfrontal extension or predominantly sinus patient, we should think transcranial approach is super than other approach. For small cell nephrotic constriction, fibrosed pituitary adenomas, or postoperative apexia of residual supracell tumor. So with unilateral subfrontal craniotomy combined with laminar terminalis approach when necessary. Serial craniotomy was indicated for tumors with dominant paracceleration, particularly with significant cavernous sinus infection. This serial approach, and this is the transcranial transversal approach. And we can see the corridor that we have. We can compare between we go first, this approach, transcranial approach, for peritoneal approach, and transcranial transversal. This is endonasal endoscopy, transcranial approach, cause the panoramic view and provides explicit visualization of medical roots and rapid direct access to sphenoidal sinus, clivus, stellar, and paracellar. It will make a better visualization of the ICA, optic nerve, chiasm, thus minimizing the chance of catastrophic complication. So this is what paradigm shift of treatment. More to the end, we will find that people like to do more minimal invasive and choose the choice and the good choice. But actually, it's not super for all of the cases. So we have to know that each cases have the special things to consider. So it's not this slide. It's not provide that the endoscope is super for every other approach. This is a transsphenoidal approach, and this is the equipment that we have. This is the position. We have to see in front of the operator is the video, and if you have a assistant, it should be here, and he will have the video here. Okay, but in our hospital, I have to do it by myself with the our resident assist. So I will do it from here, this, and this is the video. And this is the view that we really want to achieve. So medical evolution in neurosurgery, for example, is surgical management of pituitary adenomas, is a change for getting more minimal invasive. And but as I told you before that some cases always need special things to consider. So minimal invasive as this not super with other approach, but we have to consider the patient, and we have to consider what we have from the imaging and the clinical symptom. Tanton and Horsley in the 19th century do the transcranial pituitary surgeries. Sloffler in early 1900s do transsphenoidal route to cellular region, and in 1960 the introduction of operating microscope into transsphenoidal surgery. This is our patient from 2018 to 2020. Actually, we have to stop at 2020 because of the pandemic COVID-19, and we want to try to start again this at the middle of July, but what happened is the number of COVID-19 is increased again, and some of our staff is contagious with the virus, so we have to stop and we cancel to start this transcranial approach. So surgery is the primary treatment of choice for all symptomatic patients, with the exception of those with prolactinomas. It remains still controversial whether microscopic or endoscopic surgery is the gold standard. Type of surgery has revolutionized the approach to several hypothalamic pituitary disease and is usually effective and well tolerated by the patient. Long-term follow-up after surgery varies depending on the underlying pathology, and in persistent or relapsed cases after neurosurgery, it's considered treatment including repeated surgery, radiotherapy, and medical therapy. Management based on multidisciplinary team, including neurosurgeons, endocrinologists, neurologists, and intensive care teams is crucial. In our center, we have a neuroendocrine club. So we manage a multidisciplinary team. So when we have this kind of patient, we try to discuss and which is the best treatment that we can do for the patient. Okay, these are what we have in the center between 118 to 190, 120, 2020, sorry. 14 patients underwent transcranial approach, 2 patients underwent transcranial approach, and 2 persons died before undergoing. So pathology result that we found mostly were macroadenoma hypophysis, 75%. So thank you very much.
Thank you, Professor Rida, for your presentation. We will have discussion in the end of the session. The next speaker will be Professor Dr. Nyoman Golden, MD PhD, from Sanglah General Hospital, Udayana University, Bali.
Can I share my screen?
Yes, Professor Dr. Nyoman Golden will give talk about sphenoid wing meningioma, a modification to casting classification system based on result of 29 consecutive patients. Dr. Golden, time is yours. Do you have recorded video or you will give direct talk?
I will present directly.
Okay.
Can I share my screen?
Okay, please. 15 minutes. We will give you one if you're ready in 10 minutes.
Please host this. Give me share my screen.
Is Dr. Bayu, please help.
Dr.
Golden ada di Dr. Golden ada di co-host.
Dr. Golden, you're already in co-host, Doc.
You are already co-host. You can share screen using your computer, Doctor.
Let me check first. Can you see? No?
Not yet.
Sorry. Can you guide me from this?
Please share screen, please, and then you choose the file that you want to share, or you can choose your desktop so you can share your computer screen directly. You can push the button share screen, green button in the center.
Yes, I already. Yes.
Bawah share screen, terus pilih filenya, Dok, atau share langsung desktop, itu yang kiri, paling kiri biasanya, pojok kiri atasnya. Filenya dipilih yang mau di-share.
Sudah ya? You can see no?
Not yet, sir. Oh, Maggie, kalau untuk menghemat waktu, kita pembicara selanjutnya dulu bagaimana, Dok? Dr. Golden, kalau diizinkan, saya ke Dr. Agung dulu.
Kayaknya speakernya apa? Headsetnya dilepas, Dok.
Please wait, please.
Dr. Golden, Dr. Golden, halo.
Waduh.
Lama. Kita ke Dr. Agung Budi dulu aja ya. Tolong Dr. Golden ditelepon mungkin. Supaya waktunya nggak terbuang. Dr. Golden. Mas, halo. Bisa dengar saya? Bisa dengar saya? Yang bantu Dr. Golden? Bisa dengar saya? Itu sementara saya skip ke bicara selanjutnya dulu aja ya, supaya ada waktu
baik,
untuk
Dok.
betulin.
Setelah siap,
Ya,
Dok,
saya
kita
majukan Dr.
siapkan.
Agung dulu mungkin ya.
Mohon
Dibetulkan
maaf,
dulu
Dokter.
aja.
Kami
Iya, enggak
siapkan.
apa-apa.
Terima kasih.
Gitu. Terima kasih. Dr. Agung Budi Setiono, please. Are you ready?
Okay, let me share my
Yes,
screen.
let me introduce you. Dr. Agung Budi Sutiono is a neurosurgeon staff from University of Pajajaran Hasan Sadikin Hospital Bandung. He will give talk about anterior petrosal approach, causal approach, single institution experience in Bandung, Indonesia. He is a graduate from Bandung. He has finished PhD program from Graduate Department Social Intelligence Informatics, the University of Electoral Community, Tokyo, Japan. He has also got Doctor of Medical Science from Department of Surgery, Keio University, Tokyo, Japan. Dr. Agung, are you going to give direct talk or recorded video?
Yes, I have shared my screen already.
Okay, so
Can you see it?
yes, I can see it. 10 minutes, I will give you a warning. You'll be get 10 minutes. So
Okay,
please,
thank you very much.
You can start your presentation.
Yes, okay. Good afternoon, everybody. So today I would like to share our experience about the anterotranspetrosal approach or Professor Kausi approach. This is one of our single experience in Bandung, Indonesia. So as you know that the lesion in the middle fossa and posterior fossa is still challenging, especially for one-step surgery to access the middle and posterior fossa. And we know that the compact of the skull base is neurovascular structures are the most potential injured during surgery. And also the anterotranspetrosal approach or Kawasis approach is one of the surgical technique that can be possibly accessed in one-step surgery for the lesion located in the middle and posterior fossa tumor, such as meningiomas, schwannomas, or even other lesions. And this is our study of the anatomy, microanatomy. This is an en bloc study from the cadaver specimens, has been published previously on 2015. And as we know that this is the middle fossa, this is brainstem or pons that has been cutted. And this is a root entry zone of the fifth nerve. So actually this is the posterior fossa. So this is another direction of the posterior fossa and middle fossa as well. So we can see here the fifth nerve course coming to the Meckel's cave. And another study that should be known to do anterotranspetrosal approach is the location of GSPN. Because you know, if we cut the GSPN, the complication like lacrimation disturbance will occur. So this is very nice study, has been done by our team. This is the GSPN, greater petrosal nerve, which located between periosteal dura, not between periosteal and meningeal dura. So once you dissect extradurally, so this is the bone, you will find this layer, and you should cut the periosteal dura, so you can preserve the GSPN. And this is the conceptual of the course of GSPN here. So this is internal acoustic canal. This is facial nerve. This is a CP angle. So GSPN is covered by the periosteal dura here. I would like to show one of the example in our surgery. This is one of the small left petroclival meningiomas. You can see here on the left side attached on the petros. and the clypeus partial in the upper part of the clypeus, and bone CD showing the internal acoustic canal, and one of the petrous apex is seems to be more air cells, and the DSA show the course of the vein is quite good, because some of the veins sometimes they not coming into the suprapetrosal sinus, but sometimes they course into spinobasal type. So this one of the, this is not complicated or how can I say, difficult surgery, but we have to avoid injure this kind of vein. This is the position, supine position, and the top of the surgery is a zygoma, a little bit extended from the lateral side, and the skin incision is like a U shape here to make a flap after opening the petrous apex. So after craniotomy, this one, we can see the dura mater. So the craniotomy should be go to the base as best as possible. So you can go directly to this temporal base here. Once you open it, you have to dissect and find the GSPN. From the posterior to the anterior part, you will see the GSPN courses from the hiatus petrous, the lateral part of the petrous bone. You should be careful to find this GSPN. And then after that, you go further anteriorly, then you can find the MMA, middle meningeal artery. We should cut it to make a wide angle or wide exposure during drilling Kawasa's triangle. And then one of the tips is that you should cut at least 3 millimeters from the foramen spinosum in order to avoid the bleeding from the vein or even the artery. And after that, you can put the bone wax to avoid the bleeding, then more dissect until you find the Kawasa's triangle. The board is anterior is a trigeminal impression here. This is petrous apex. This is GSPN courses like this. So this part should be drilled carefully. And then once you open this, you can see posterior fossa dura. And you have to lift the temporal base as high as like the petrous edge like this. And after that, you drill the Kawasa's triangle slowly. I usually use the smallest drill. It will be better if you have like a narrow tip drill, not the diamond drill, because this is very narrow. There are some part of these petrous apex, two kind of parts. Sometimes they flat, sometimes they look so high like this. Then maybe the flattened petrous apex sometimes much more difficult because the space is very narrow. After you drill, you will find the posterior fossa dura. Then you cut the temporal dura straight and make a T shape like this. Go straight downward and make a T shape. Then you will see the tentorium here. After you see the tentorium, you can continue to open the posterior fossa dura. Then you will see one of the tentorium in one line. Then you can find the suprapetrosal sinus, then you can ligate it slowly. After that, after you cut the tentorium slowly, you have to know and confirm the location of the fourth nerve. It's really, really very thin. It's about 1 millimeters at the edge of the tentorium. And then you have to preserve it. Otherwise, the patient will have a diplopia. Then you can dissect the tentorium anterior to posteriorly, slowly make a plane from each layer of the tumors. And we have to preserve the ACA. Sometimes ACA can be seen here and fourth nerve as well. And then we should dissect the tumor. After you open the Meckel's cave, the fifth nerve, it's going to be very easy to mobilize downward and upward once you take out the tumor. And then After we remove the tumor, the fifth nerve will be seen very clearly like this. This is the down part of the tumor. This is the upper part, the smallest part. After remove, this is the last part of the tumor. And if you dissect carefully, you can preserve the perforating artery to the brainstem or to the pons. You have to, sometimes you combine between dissect and use ultrasonic aspirator to remove the tumors. And this is after remove, we can see here basilar artery and pons here very nicely. And after that, the closure should be covered the air cell here in order to avoid the CSF leakage. And we put it a fibrin glue to make a shield. And the last one, we take abdominal fat to cover the last part, and we use the pericranial flap to cover as the last part of the layer. This is 2 days after surgery, and this is the CT scan control after surgery. Seems to be total removal. Then between 2016 and 2019, we have 38 cases. Meningioma 29 cases with 19 cases total removal. Schwannoma 7 cases, 4 cases total removal, and epidermoid 2 cases. All of the 2 cases we can do it in total removal. So I think the anterior transpetral ports or Kawase ports is one of the step surgery to access middle and posterior fossa dura. And I don't find any other approach in one step to access middle and posterior fossa unless transpetrosal approach. And it is possible to preserve nearby all of the neurovascular structures in the middle and posterior fossa if you can do it carefully. And also in our service, it's about 65.78%. We can do it in total removal through the anterior transpetral support. And the rest, sometimes I combine with the radiosurgery, and I will follow within 3 months, 6 months, until 1 year. If it is recurred, maybe I will consider to reoperate or even do radiation again, because gamma knife in Indonesia is quite expensive, and we just only have 2 gamma knife in Jakarta. I think that's all. Thank you very much. I would like to acknowledge my mentor, Professor Kawase, Professor Yoshida, and Professor Toda, and all of my mentors around the world. Thank you very much.
Thank you very much, Dr. Agung Budi. We continue with next speaker, but I will back to Dr. Nyoman Golden. Are you ready, Dr. Golden? Dr. Golden, slide-nya sudah bisa, Dok? Dokter mau sekarang atau setelah nanti terakhir, Dok? Dr. Golden? Masih di mute, Dok?
I can try now.
Okay, please. Please try, Dok.
Give me host, yeah. Host disable participating screen.
Coba
Please
tolong
allow
Mas,
me to.
Mas Bayu.
Oke, bisa dicoba, Dok, share screen-nya.
Sudah co-host, Dok?
Steve. Hello? Hello, is possible?
Belum kelihatan, Dok?
Cepat nih, ntar dulu, ada asistenku. Nih.
Ya, sudah, Dok. Kelihatan, Dok.
Oke.
Ya, 15 menit, Dok. Nanti setelah 10 menit kita ingatkan. Silakan, Dok.
Okay. Thank you very much. Thank you, Mr. Chairman, and thank you for the committee for giving me opportunity to present my work in this meeting. I would like to talk my proposing modification classification of spin with wing meningioma. As introduction, the Kasing and his colleague first classified this meningioma into 4 categories based on symptom and surgical observation and post-mortem examination. So the first is we call simply a medial group, and the second is a middle group, and the third actually is a lateral or paternal group, but they divided into two different and plaque and globoid paternal meningioma. Since then, there are many classifications available in the literature, like Bonal and al. In 1980, they group this tumor into 3 different groups. They included both in plaque and globoid tumor. Pahano and Bitar in 1960 and 1986 divided this tumor simply into medial group and lateral group. And Rosser et al. 2005 made little bit modification, especially in medial group. They divided into different groups on the basis of cavernous sinus invasion. So why we have to divide or the meningioma that arise along the sphenoid ridge into different groups? Because they have their own unique behavior, as like sphenoid medial group, because their proximity to the optic canal, to the important blood vessel, of course they have higher rate of when the tumor moves laterally, there will be less compression to these structures. Therefore, less visual impairment or less other cranial nerve. Although Kasing classification until now is still the most valid. However, based on our experience and our practice, this Kasing classification still can be modified. Therefore, I analyze my cases on the basis of preceding symptom, imaging studies, surgical observation, surgical radicality, and surgical complication in 29 patients with globoid tumor sphenoid meningioma. So for the purpose of this proposed classification, we define medial globoid tumor is a is a sphenoid ridge meningioma rise from 1/3 of medial sphenoid ridge, represent medial posterior to anterior projecting segment and most adjacent to the anterior cranial process, with or without cavernous sinus invasion, while a lateral group comprises of 2/3 of sphenoid ridge with the lateral margin just close to the pterion. So pterion is not included in this lateral group. Therefore, we redefine that paternal meningioma is a globoid tumor with hyperostosis that originated from the pterion, spread to the temporal bone, to the superficial temporal region, and therefore it is most likely a convexity meningioma rather than a skull-based meningioma. This is the imaging of our series. This is paternal globoid tumor, and in our modification, this is removed from sphenoid wing meningioma classification. This is lateral groove. This is about the same as the middle groove in Kasing classification. This one is a medial globoid tumor with cavernous sinus invasion, and this 2 below is a medial globoid tumor without cavernous sinus invasion. This is the presenting symptom of our series. Of course, that the medial groove will have higher rate of visual impairment, ocular paresis than the lateral groove. This is another characteristic of my patient in the series. And this 4 data support our idea to modify the classification of casing of a sphenoid ring meningioma. As you can see, this pteronal group has 100% total removal, and they have no vascular engagement. The complication rate is very low than the lateral or medial group. Therefore, I think that this pteronal group should be excluded from the sphenoid wing meningioma. This post-operative complication also support our idea to exclude the pteronal group of casing classification from sphenoid meningioma. This imaging and operative surgical report or observation show us that this pteronal group is actually convexity meningioma. After removing all the fragment, the aspergillosis bone, we can remove the tumor totally and block removal without brain retraction. And at the end of surgery, you can see that there is no vascular encasement. There is no direct compression to the important structure, to the skull-based structures. This is a lateral group in our modification, but it is a middle group in casing classification. As you can see, this tumor also has hyperostotic, and this lateral group also can encase the major cerebral vessel, especially in the proximal one, and also can nerve. This is a medial group. This is a complex tumor. It has hyperostotic bone, and it extends to the orbit and to the cavernous sinus. Of course, that we have to remove all the hyperostotic bone, and then we will have ample surgical space to remove the tumor in the orbit as well as in the intracardial portion. And after removing all this hyperostotic bone, we have ample surgical space to remove the tumor intracranially. As you can see, the tumor will be easy to detach from the attachment, and the good surgical access. In this part, the ACA is completely encased by the tumor, so small random tumor was left behind. However, in this proximal blood vessel, we still have good arachnoid space. Therefore, we can remove the tumor easily without leaving any random tumor into the blood vessel. And at the end of surgery, we can also preserve the third nerve. This is the third nerve. And at that point, we have to avoid any use less cautery to avoid injury to the third nerve. This is the another patient with the medial group. The operation is just done 1 month ago. This tumor is encased the blood vessel strongly, so there is no good surgical space between the tumor and the blood vessel. So a small random tumor strongly attached to the blood vessel was left behind. In this case, you can see that the blood vessel is strongly encased by the tumor, and then small random tumor was left behind. So there are 3 modifications of a casing classification we made. First, the pteronal group is removed. As I said, that this most likely is a convexity meningioma because it has 100% gross total, it does not involve the cranial nerve or any skull-based structures. And the middle group in our in the casting classification was removed and replaced by lateral group in our modification. Then this is comprised of 2/3 of the lateral sphenoid ridge without including meterion. And the medial group should be divided into 2 groups on the basis of cavernous-sinus invasion. So medial and lateral group should be separated because they have different behavior in terms of clinical presentation, cavernous-sinus involvement, vascular encasement, surgical challenges. Of course, the medial group has more surgical challenging for the neurosurgeon, and surgical radicality is much less in the medial group than the lateral group. And of course, that the complication rate in the medial group much higher than the lateral group.
Excuse me, Prof. 4 minutes left. 4.
Okay. Yes. Medial sphenoid group further should be divided into different groups based on cavernous-sinus invasion. In summary, based on our clinical presentation, imaging studies, microsurgical observation, and surgical outcome, we propose globoid sphenoid meningioma divided into 2 distinct groups, medial and lateral group. And medial should be divided further into cavernous-sinus invasion or without cavernous-sinus invasion. And paternal group should type 2, type 4 in casting classification not included in sphenoid meningioma, but it is included to the convexity meningioma. And this modification should be used as guidance during informed consent and surgical planning. Thank you.
Thank you, Dr. Golden. Now we go to the last speaker, Dr. Andi Ikhwan. Are you ready? Dr. Andi Ikhwan?
Okay. Yep.
Dr. Andi Ikhwan. Dr. Andi Ikhwan is Dr. Neurosurgeon from Neurosurgery Department of Medical Faculty Hasanuddin University Hospital. He is graduate from Department of Surgery Erlangga University Indonesia, and we will give talk about cyclin B, CDK1, and CDK4 in meningioma. Dr. Iwan, please.
Okay. Here a slide is shared.
You will give a direct talk or recorded video?
I directly.
Okay, please. Time is yours.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. I am Ikhwan from Makassar, staff at Neurosurgery Department of Medical Faculty of Hasanuddin University Makassar. Thanks for Dr. Hadian and ACNS Committee for opportunity to me to present on second ACNS Congress. Today I will like to talk about expression cyclin B, CDK1, and CDK4 in meningioma. Yes. Introduction. Meningioma are most common primary intracranial tumor. Incidence is about 1/3 or 36%. In USA, the incidence prevalence is about 97/100,000. From WHO classification, tumor meningioma divided in 3 grades. First grade is grade 1, that is represent approximately 90%. It's the most common. And grade 2, about 7%, and the last is grade 3, rare but the prognostic. Surgery and radiotherapy are the standard treatment for meningioma. But in some cases, surgery can reach total removal. And in case of recurrent meningioma and some condition that make surgery cannot perform because due to condition of patient and or location of tumor, surgery can perform. So radiotherapy and pharmacotherapy will be the second choice. The role of pharmacotherapy in all types of meningioma remain controversial. Some of treatment from VEGF antibody like bevacizumab is still on study. CDK1 and cyclin B is the family of enzyme of tyrosine kinase that play a significant role in controlling sickle cell, especially for cyclin B is important for the entry of mitosis. In many cancer, overexpression of some of CDK and cyclin can lead abnormal cellular proliferation and cancer progression. Due to such dysregulation of CDK, many cancer targeting of this family of enzyme is studied and make this family promising strategy to treatment multiple cancer. It's about 1 year we study expressing cyclin B, CDK1, and CDK4 from the patient meningioma. We analyze from fresh or frozen specimen representing virus of meningioma. Sample collected about 96 specimen from 2019 and 2021. The sample is recurrent meningioma and meningioma that got radiotherapy excluded from the study. Sample then analysis with real-time PCR. The result of our study is mean age of patients is about 40 years old, 50 years old, and the range is about 38 to 98 years old. Woman is dominant, is about 3 times than men. And the location is the most common is convexity, is about 38%, then sphenoid wing. Yes. Here's the distribution of pathology type of meningioma. Grade 1 meningothelial meningioma is the most common, is about 23%. Grade 1 is most common, is about 50%. Then grade 2 about 30%, and the last is grade 3, about 20%. From real-time expression of cyclin B, we got the result is the relative expression of level range from 0.1 to 1.6. Average is the level is higher than normal tissue cell. And in grade 1, the range is from 0.1 to 1.6. The average is 0.9%. The average is increased linear with the grade of meningioma. Then we analyze with Kruskal Wills. We got the positive correlation between grading of pathology with the expression of mRNA cyclin B. This is the distribution of the expression, relative gene expression from cyclin B with the grading of meningioma. We can see that grading 1, yeah, the most lower at the grade 1, the highest at the grade 3, and cyclin B. Yes. The overexpression is similar with the other tumor and other side, like the malignant expression at the lymphocyte and the neuroendocrine tumor. At the ASCC the study got the overexpression of cyclin B2, and in metastatic lung, expression of MRCDK1, we got the same result too. The relative gain expression is higher than normal cell. The level range about 1.2 to 6.6, 9.9. The average is about 5.80. The expression is increased linear with the grading of meningioma. In grade 1, the average is about 5.30. The range is increased. In grade 3, the average is about 6.38. There is a positive correlation between grading of pathology with the expression of MRCDK1. Yeah, this is the distribution of the gain expression at the grade 1, grade 2, and grade 3. There are increasing result from grade 1, grade 2, and grade 3. Yes. The same result is got from the other study at the other cancer like pancreatic adenocarcinoma. There is overexpression of CDK1, cyclin A, and cyclin B. It's about 45%. Overexpression CDK1 too. Study at the colorectal cancer, and CDK1 is the correlation positive with the poor prognosis of the patient. In the MRCDK4, the result is same with the cyclin B and cyclin 1. There is increasing of expression more than the normal level of tissue. The relative gain expression is from 0.2 to 1.88. Then average is 0.7. There is increasing of the average linear with the grading of meningioma. At grade 1, the average is only 0.880. Yes, and the little bit increase in grade 2, 0.81. From the statistical analysis, we got the positive correlation between grading of pathology classification with the expression of CDK4. This is the distribution of the expression of CDK4 with the grading of meningioma. Yes, the lowest value at the grade 1 and the highest value at the grade 3. The overexpression of CDK4 is a study with the other cancer, like brain cancer, glioblastoma. CDK4 is amplified in 50%. In osteosarcoma patient too, the elevated of CDK4 is correlated with clinopathology features of the tumors. From the promising of result of genetic and clinical study that the CDK4 now to be studied to be a future pharmacotherapy for the many cancer. Use the CDK inhibitor like palbociclib, ribociclib, and abemaciclib. The conclusion is our study is there are significant association between cyclin B, CDK1, and CDK4 overexpression and grading pathology meningioma, indicating that cyclin B, CDK1, and CDK4 may be a potential biomarker or in meningioma, and in future it can be studied for the pharmacotherapy treatment for the to treat meningioma. Thank you.
Thank you, Dr. Andi Ivan. We can continue to the discussion. Please, we have maybe 10 minutes for discussion. Maybe there are some questions for the participant. You can put in the chat box or raise hand. You can directly ask the speaker. Please. Maybe I will ask Professor Charlie Teo. Professor Charlie, are you still with us?
Yes,
Yeah,
I'm here.
maybe do you have tips how to identify the margin between the tumor and the normal tissue?
Yeah,
Because
look,
you didn't use any intraoperative monitoring, right?
I don't use any intraoperative monitoring. I just totally depend on the tips that you talk about, the tips of how to differentiate normal tissue from abnormal tissue. And Yashigul taught me many of the things that I use today to make that differentiation. The first is how it looks. And if you can't see that it looks different, then just keep increasing your magnification to see if there's any subtle difference in the way it looks. Is it shinier? Is it duller? Is it a different color, grayer, pinker? That's the first thing. The next thing is how it sounds. And so as it goes up the sucker, tumor sounds different to normal tissue. A tumor sounds almost like mucus going up the sucker. Next is how it burns. When you use bipolar forceps, the bipolar forceps applied to tumor makes the cells overheat and bubble, and it bubbles and liquefies, as opposed to brain. When you coagulate, bipolar coagulate brain, it chars and becomes dark and burnt. And then, of course, you've got to identify normal tissue. Normal tissue have tiny little petechiae or tiny little vessels in it, and the tumors don't have that. And it goes on and on and on. The way it feels, the way it looks, the way it sounds, they're all very subtle hints or tips as to how to differentiate tumor from normal tissue. And they're all the features of a glioma, whether it's in the brainstem or in the cerebrum. It's all the same features, and also the same features regardless of the grade. Low grade or high grade, they all have the same features of how they coagulate, how they feel, how they look, and how they sound.
Okay. Any question for participants? How about the use of dye?
Excuse me, Doctor.
Please, Dr.
May
Rida,
I
please.
ask some question?
Prof. Rida, please.
I already make this raise hands.
Okay, I'm sorry. Please.
Charlie, how are you?
I'm very good. It's so good to see you.
Yeah, it's been a long time. It's 7 years, around 7 years.
Too long.
Like, it's always like a new blood coming to my vessels. Every time I hear something from you, like a new spirits come. Yeah, well, it's not so easy to do like what you say just now, to differentiate the voice and to feel, and but it takes an experience to do that. But the things that I want to ask is, do you have some things to do that you do after operation for the edema around its area? I mean, what do you have something that you give to the patient, or the position what you did? Thank you.
Well, again, I can tell you now that at the end of my career, I can honestly say to you that the number of times I've had to place a shunt into a patient with a brainstem glioma is zero. I can't remember. So I guess what I'm trying to say is that if you do a very good resection and take out the tumor, then there's very little edema in the brainstem, because the edema all settles down once the tumor's out. The edema is a real problem if you leave a significant proportion of the tumor behind. And you're absolutely right. You should probably leave an EVD in. You should put them on high-dose steroids, because if they get significant swelling of the brainstem, then they're going to block off their aqueduct and they're going to get secondary hydrocephalus. So yes, your point is a very good point. and that is that edema is a major problem in the brainstem if you leave tumor behind. But again, if you don't mind, if you go back to my original statement, the most important thing with brainstem glioma surgery is making the right diagnosis. You have to differentiate focal from diffuse. You start operating on diffuse tumors, and believe me, I've made the mistake. You'll get a lot of problems and bad outcomes. It's got to be focal. You've got to look at the T1 and the T2. And remember, Fred Epstein used to talk about how T1 and T2 were perfectly overlapping. So the T1 image is exactly the same as the T2 image. And if that's not the case, and if there's no clear demarcation, and you see any sort of resemblance of normal tracks going through the tumor, back off. But if it's the clear demarcation, T1 equals T2, then that's a focal tumor, and your intention is to get that tumor out, just like a tumor in any other part of the brain.
Okay. Thank you, Charlie.
Thank you. Another question maybe for another speaker. Please, Dr. Golden.
Yeah, I have a question to Charles. Yeah. So regarding the diagnosis, MRI preoperatively, how can we sure that this tumor has a good margin? And my second question is that if we really know that this is a diffuse brainstem glioma, do you routinely do some biopsy? Because in my opinion, diffuse brainstem glioma, sometimes not easy to find the specimen for the pathology. And the pathological report always, because we crush the tumor, and then our pathologist cannot clearly read this pathology.
Yep.
So can we just rely on the imaging? I mean, on MRI for a diffuse to go for the treatment. I mean, like radiation. Thank you.
Okay, so they're all very good points. If you don't mind, let's talk about them right from the start. So the first thing you've got to talk about is, what are the radiological criteria to diagnose a DMG? And the answer is, we don't know. We don't know because no one has properly defined the radiological criteria. If you look through the literature, and I promise you, Dr. Golden, I've looked through more than 30 articles, radiological articles, looking for someone to come up with a clear definition of what is a DMG. There is no clear definition. Some people say it has to be in the pons. Well, that's not right, because you can get diffuse tumors in the midbrain and the medulla. Some people say it has to occupy more than 50% of the pons. Well, that's not true, because if you catch them early, they're going to occupy less than 50% of the pons. Some people say they have to grow ventrally and extend dorsally. Well, other people say that's wrong. Other people say that if there's an exophytic component, then it's focal. That's not right either. And there is no definition. It's crazy that no one has ever come up with a definition. And that's why so many children are being sent to their death unnecessarily when they have the false diagnosis of a DMG made. And in fact, it's not a DMG, it's a focal tumor. So I'm sorry, I can't answer your question, but I can simply say this, that you look very carefully at the T2. And if you see those crossing horizontal pontocerebellar fibers, you know what I'm talking about, then
Yes,
that's likely to be a DMG. If you don't see any crossing pontocerebellar fibers, then please think very carefully. That should raise a red flag. If there's no crossing pontocerebellar fibers, you say to yourself, could this be focal? You look at the T1, you look at the T2, you look at the contrast, and you try and define the edges of that tumor, because sometimes the normal brainstem is a very thin rim, or sometimes it's pushed all the way over to the side and you think it's a cerebral peduncle. And I used to say the sign that was the most obvious sign was a symmetrical encasement of the basilar artery. But as you saw from my presentation, there were ependymomas that had perfectly symmetrical encasement of the basilar artery. And that's why they were falsely diagnosed as DMG. And in fact, they were ependymomas. So it's a very difficult, I'm sorry, but there's no clear definition of focal versus diffuse. Okay, once you've decided the tumor is diffuse, should you biopsy it? Well, you raise a very good point. The first point you raise is, it is risky. So even if you're just doing a biopsy, there is a significant risk that you're going to make the patient worse. That's the first thing. The second thing is, if you don't have a lab that can differentiate the different types of gene expressions and do molecular sequencing, then there's really not much use in doing a biopsy, because the major reason to do a biopsy is so that you can enter that child onto a trial based on the molecular sequencing of that tumor. And if they have a particular overexpression of a gene, then of course they fall into some research category. But if you don't have that available, if you don't have those facilities available, there's no benefit in doing a biopsy of a diffuse tumor. And then finally, you alluded to the H3K27M mutation. And, there's been so much literature written on the H3K27M mutations and expressions. And the jury is still out. We used to say that if they were H3K27M positive, they were diffuse, they were malignant, there's nothing you can do. That is not true. And I'm sure you've heard David Ellison speak, and David Ellison is the world authority on these expressions. And in fact, he's even written a paper stating that, H3K27M positivity doesn't necessarily mean diffuse glioma. There are low-grade gliomas that can have that expression. There are other tumors like ependymomas that can have that expression. So, even the H3K27 identification is not necessarily the answer to identifying diffuse from focal.
Okay, thank you.
Yeah. Thank you. Thank you all speaker. Because the limited of time, I think we must close this session because we have continued to the next session. Right, Dr. Yuda? The time is
right. I think we will directly continue to the second session of school base.
Okay. Thank you. I close this session. Thank you very much for all the speaker, Professor Rida, Charlie. Thank you so much, Dr. Golden, Dr. Andi Ivan, and Dr. Agung Kristono. Thank you. I give to the faculty.
I'll see you tomorrow.
See you tomorrow. Thank you, Charlie.
Bye-bye.
See you tomorrow, Prof.
Thank you.
Thank you so much.
Ini berlanjutnya di sini ya? Anunya, sesinya.
Iya,
lanjut.
Lanjut di sini langsung.
Oh, lanjut di sini. Tadi Dokter Budi pamit masalahnya. Padahal dia moderator selanjutnya.
Walah.
Aku udah balik lagi.
Ya, makanya.
Kamarnya sama.
Pergi kemana ini?
Ya wes.
Monggo, silakan.
Alright, we'll continue for the second session of school-based oncology. Our moderator for the second session is Dr. Agung Budistiono. Good afternoon, sir.
Yes, good afternoon. I'm ready for that.
Okay, Dr. Agung Budistiono, neurosurgeon, is from General Hospital of Hasan Sadikin, Bandung, Indonesia, and now is a staff at the neurosurgery department at the Faculty of Pajajaran University. Okay, Doc, I think for the efficiency of time, the session, I'll give it to you. The session is yours.
Okay, thank you very much for direct presentation. I think I would like to introduce first Dr. Renindra as the first presenter here. He's one of the senior staff at the University of Indonesia. And then
Mute, Gung.
please, Dr. Renindra, the time is yours.
Thank you, Dr. Agung. My session is being recorded. I've sent the recording.
Good afternoon. My name is Renindra Ananda Aman. from Universitas Indonesia. First, I would like to congratulate the committee, Dr. Hadi and his team for organizing this virtual international conference. I would like to thank for giving me the opportunity to share this topic, which is spinoorbital meningiomas, diagnosis and treatment. Spinoorbital meningiomas, or SOMs, are exophytic tumor mass that infiltrates the bone at the splenic wing, the lateral orbital wall, the orbital roof, and also extending to superior orbital fissure. These SOMs are uncommon, just accounting for 0.2% to 9% of all meningiomas. They usually originate from the dura of the splenic wing bone, and they also exhibit interosseous tumor growth, which leads to hyperostosis. And these intradural tumor growth may take various forms, ranging from a thin carpet-like soft tissue and widespread unplugged tumor to a large mass. Hyperostosis and intradural portions of tumor can also cause compression to the optic nerve, other cranial nerves, the internal carotid artery, and invasion of the cavernous sinus. So these factors make aggressive surgical removal an arduous challenge. The classic triad of clinical features are proptosis. There are several potential mechanisms that have been suggested for proptosis. One is the direct progression of the tumor into the orbit, and also contribution of venous obstruction due to tumor in the cavernous sinus and the superior orbital fissure, causing reduction of venous drainage from the orbit. Second, there are also decreased visual acuity, which can be accompanied with ophthalmoplegia. For diagnosis, usually a CT scan or MRI is done. As we can see here, in the right orbital wall, there is a hyperostosis, enlargement of the orbital wall, and also the temporal bone, and it protrudes into the orbit, the right orbit, and also will push the eyeball, the right eyeball, outwards, which can cause proptosis. In the MRI, this lesion or this hyperostosis is hypointense, shown hypointense here. And you can see unplugged lesion is a carpet thin-like lesion, which enhanced with contrast. Usually this is the unplugged meningioma. There are several ways we can measure the proptotic index. And this is one way, which is in the pathological eye, the distance A is compared to the distance B in the normal eye. And it is called or defined proptosis if it's more than 2 millimeter difference. So the treatment is usually surgical, and the surgical technique, the patient is placed supine on the operating table. The head is rotated approximately 30 to 45 degrees to the contralateral side and placed in a Mayfield head holder. And the incision usually begins 1 centimeter in front of the tragus and a coronary line to the midline and past the midline to the contralateral side. Here, as you can see, the hyperostosis portion of the temporal bone and from the literature. And this is from one of our cases here. So a standard skin incision, a pericranial flap, and a temporal muscle elevation is done. After a standard craniotomy, a standard frontotemporal craniotomy is performed. The hyperostotic bone is resected with a high-speed cutting drill. and the lateral orbital wall is removed until you identify, or we can see the periorbital fat, which is right behind the pathological eye. You can see the muscle has been elevated. And a standard craniotomy is performed with a perforator. And then the hyperostotic bone is resected with a diamond burr, with a combination also with a Ranger or Carrison. Every time we do the resection, it's been done extradurally until we identify the periorbital fat, and we continue the thinning of the bone by using diamond drills and also Ranger. And the intraoperative bleeding is controlled by using bone wax. And until we are satisfied that the periorbital fat has been moved or can be mobilized backwards, then we finish the surgery. In some cases, we do the section below the frontal zygomatic processes, so we can mobilize the periorbital fat, because sometimes there are adhesions and also the thinning of the bone during the using the diamond burr. So we present our case series for the last 6 years. We had 264 patients, with the majority female patients, with an age range of 29 to 71 years. All female patients had history of hormonal contraceptive use. From pathological examination, it revealed that WHO grade 1 for around 87%, and WH2 grade 2, 12%. So the majority patients were in the 41 to 50 years old range, and the location of the lesion, the right and left, are nearly the same. After surgery, around 151 patients had decrease of proptotic index, with around 100 had no change of the proptotic index. And the fundoscopic findings, around 106 patients had papular atrophy, and only 20% had ophthalmoparesis. Regarding visual acuity, we found no significant correlation between pre and post-operative visual acuity. And most of them came to our hospital were already blind or severe impairment. And according to the literature, Oya et al. Concluded that the severe preoperative visual deficit was the only statistically significant risk factor for unfavorable post-operative vision. Therefore, when the patient are already blind, then only a small chance that will recover. So post-operative complications and recurrence, there were wound infections in 1%, CSF leakage 1%, cranial nerve palsy 4.2%, and recurrence around 12%. This is a case, a sample case, with a patient, female patient, 50 years old, with the proptosis in the left eye. As you can see, there is a hyperostosis of the orbital wall and the temporal bone, and a resection was done. After the post-operative CT scan, as you can see, the hypothalamic bone has been removed and resected. This is the post-op CT scan. And the post-op clinically, as you can see, that there is improvement of the left eye. So in conclusion, the surgical resection of some and bone hyperostosis remains a challenge to achieve very good results. The spinoorbital meningioma patients postoperatively showed markedly improvement in proptotic index, and the visual acuity were not markedly improved after surgery, since the majority of patients preoperatively were either blind or severely impaired. So this concludes of my presentation, and thank you for your attention.
Well, thank you very much, Dr. Renendra. So we'll proceed to the next presenters. The next presenter will be Dr. Rahadian Indarto. He will present about the giant acoustic schwannoma technical note. You know that Dr. Rahadian completed his medical school residency as well as PhD in Airlangga University. Please, Dr. Rahadian, time is yours.
Sorry. Thank you, Dr. Rakung. I will share my screen. Jelas ya, Mas?
Ya, jelas.
Okay, thank you for the opportunity. I will present my paper about surgical tip for giant acoustic schwannoma, focus on technical note. Okay. As we know that giant acoustic schwannoma is acoustic schwannoma with diameter more than 4 cm, and it should be measured on MRI image. And acoustic schwannoma actually occur about 0.6 until 1.9 per 100,000 population, but the case is increasing due to widespread MRI use. Giant acoustic schwannoma approximately only 1%, but in Indonesia, this case is often found in the clinic because usually patients come late. The most common symptom is hyperacusis, tinnitus, and ataxia. There are several grading systems for acoustic schwannoma. The most important thing is the principle are two things considered, namely based on the tumor size and the relationship between the tumor and surrounding anatomic structure. We often use grading according to the cause, and we see that for huge giant is a cause grade 4 with severe brain displacement and deformation of ventricle under tumor compression. There are several considerations. Hearing physiology. If tumor more than 3 cm, the chance of hearing preservation is no greater than 10%. The second one is how about the facial nerve physiology. We use Haus-Bregman to categorize the function of facial nerve. And how about the adjacent compression, especially for in the brainstem and cerebral sign. The important intraoperative monitoring is we use it because it significantly increases cortical removal and reduce mortality. You must remember that the goal of the management of vestibular schwannoma is improve quality of life, preserve neurologic function, and maintaining mortality and morbidity rates as low as possible. You must remember the natural history of vestibular schwannoma maybe follow 3 different paths: no growth or slow growth, maximum 2 mm per year, or fast growth more than 3 mm per year. There are 4 treatment options: conservative therapy with watchful waiting, radiation therapy, microsurgery, or hybrid subtotalization plus radiation. If we use radiation therapy, we must long-term follow-up is mandatory. After radiotherapy, we can use discrete for follow-up patient. There are several surgical approaches. What to consider: first, anatomical relation of the tumor, size and extent, and IAC involvement, and very important surgeon experience. Retrosegment approach usually used in majority of case, indicated for small or large tumor, and when hearing examination is called surgery. Translabiretin approach is indicated for deaf patient with large tumor, and middle fossa approach currently less used because it's very complicated approach, indicated for small canalicular tumor when hearing preservation is called operation. We must check the anatomy, relationship of tumor to the basilar artery and pica, cerebral venous anatomy. Look carefully for brainstem edema because it's high risk if we have brain edema, so brainstem violation during microdissection of the tumor capsule. So it's better to leave residual tumor and follow up or continue with radiosurgery. Give attention to the area close to brainstem, segment of cranial nerve, and continue area of tumor. Very important is surgeon experience, because the best approach for the surgeon is the one most familiar approach. Now we talk about retrosigmoid approach. Why retrosigmoid approach? Because total removal of large acoustic neuroma can be achieved by retrosigmoid approach with acceptable morbidity and mortality. Preoperative neurologic symptom recover after surgery in most cases, and this is most familiar approach. This is a sample of case, 62 years old male with floating sensation, hearing loss of the left ear and asymmetric face. He has a previously history of VP-Shan with neurologic status GCS 15 and already have facial nerve paralysis with motor and sensory examination normal. This MRI finding shows the tumor acoustic schwannoma with diameter more than 4 cm. The first tip is position. We use park bend position with head trunk up 50 degrees, flexed lateral to contralateral shoulder, and we must make sure that patient neck is obscured. So we have maintained 2 finger wide breadth and patency of jugular vein, so the venous return is okay, and we fixation the patient with tape like this position. Sometimes I put pillow in this area so the patient not sleeping. The head rotated 30 degrees and position to the patient must as close as possible to the operator, so the operator can sit behind the patient and can operate do surgery effectively. The next tip is in skin incision. We use curvilinear incision. There are several landmarks. First, POA, protuberancia orbitalis externa, and then mastoid tips. We draw the line from sigmoid sinus and transversus sinus, and we draw the craniotomy site, and then finally we draw the incision. This is a patient with intraoperative monitoring. The next tips is muscle dissection. Muscle dissection, we use layer by layer incision. So incise and the insertion and flap forward of the region. The advantage of this technique, we don't use spreader. You use muscle hook. By layer dissection, we can get wide exposure without spreader that obscure our view. And then we do a craniotomy. Burhole is performed in the asterion. This is 61 and 60% position is over the transverse sinus. It is safe as long as we use sharp perforator. We can do it safely without too much compression. The pitfall is emissary vein from the segment sinus to the bone. Sometimes bleed during craniotomy. So the tips is during this area, we use high-speed drill or plunger to remove the tumor. Dural opening, transfer sigmoid sinus must be open to expose following craniotomy. We use C-shaped dural opening. Dural opening parallel to the transverse sinus, 1 cm away, and we take with a suture. I mean, continue with system decompression, and this is important part, very crucial. Lower cranial nerve identification. We use intraoperative stimulation to identify lower cranial nerve. We use 0.2 milliampere to identify 12 cranial nerve for positive control, to make sure that our stimulator is working properly and patient is not under muscle relaxation. For facial nerves, there are several methods to identify. We can mapping using trigger EMG, or during dissection, we can use running EMG to identify the train that can be a sign of nerve irritation. So you must gently track and look for the train. If we found train, we must stop dissection. Or we can use transcranial motor epoch potential (TCMEP). This is continuous mapping that check corticobulbar tract and facial nerve function. And then we continue with tumor excision. The lower part is the first part we have removed that attached to the lower cranial nerve, and then we continue mapping the location of facial nerve, grow cranially, look for the superior pole that attached to the tentrium and the fifth nerve. It's very important to maintain sharp arachnoid dissection. The next step is adequate tumor debulking because it can easier tumor mobilization and less detraction of the brain parenchyma. Drilling of internal acoustic canal is not always necessary in giant acoustic schwannoma. This is video illustration. This is sigmoid sinus. This is obtural opening along the sinus, 1 centimeter. This is the decompression. And then we identify the lower cranial nerve, 11 nerve. And then we find the clear safe margin and open the capsule, tumor capsule. And we can start debulk the tumor using tumor forceps. You can use JUSA if you want. And arachnoid dissection is very important. From the lower cranial nerve, debulk the lower part first. Identify the lower cranial nerve and debulk as much as possible in the lower part first. And then again, arachnoid dissection is very important. We can identify the 7 nerve as long as we can keep the arachnoid. And then we continue resect the lower part as much as possible, combine between sharp resection, we use scissor, and then we can identify basilar artery. And then we continue upward. This is 11, 12 vertebralis, and then we go up. And piecemeal and identify some perforantes and use sharp dissection. This is tentorium, this is petrous vein, this is upper part, and this is fifth nerve. We can see the fifth nerve. This is tentorium, and this is final view. You can access the tumor maximal. Thank you very much.
Thank you, Dr. Hadian. It's exactly on time. Okay, we'll go to the next speaker. Will be Dr. Roland Sidabutar. He's my senior at Pajajaran University. He completed his medical school at the Christian University in Jakarta and completed the residency program as well as his master program in Pajajaran University. He did a lot of clinical fellow in all over the world. I think the time is yours, Dr. Roland.
Thank you, Moderator Dr. Agung. I already sent my video to the committee.
Okay, Doc, please wait a minute.
Congress of Neurological Surgeon for inviting and give the opportunity for me to present my talk in this virtual international conference. Today, my talk is about anterior skull-base meningioma various surgery approach. I am Roland from Neuro-Oncology, Department of Neurosurgery, Hasan Sadikin General Hospital, Medical Faculty, Universitas Pajajaran, Bandung, West Java. Anterior skull-base meningioma is the one of interesting and common case surgeries in neurosurgical field. As we can see here, the anatomical landmark where the anterior meningioma can grow to this area of the anatomy. And also this illustration can show the tumor can grow between or inside or in addition to normal vasculature structure. This area was challenging to reach because of many vital neurovascular structure crowding in this field. Our goal to take out the tumor without make further functional injury. The tumor may fill the frontal floor until tuberculum sera area. As the tumor grows, it will displace, stretch, or even encase vital structures such as olfactory nerve, usually stretched laterally, optic nerve, usually displaced upward, internal carotid artery may shift to the lateral, and if the tumor extends backward, it may push pituitary stalk backwards. Anatomical considerations for this tumor are occipitory complex, internal carotid artery, anterior cerebral artery, anterior communicating artery complex and associated perforators, optic apparatus, and also pituitary gland or infundibulary stalk. Although controversy exists as to the best surgical approach, in truth, several approaches may be suitable for a variety of tumor characteristics in this area. Several surgical approaches such as bifrontal, unifrontal, subfrontal, supraorbital keyhole approach, lateral approach, endoscopic intranasal approach were proposed to remove this tumor. Preferred surgical approach, surgical tactics, and surgical strategies is depend in every individual surgeon authority. So we can see that approach can describe as anterior corridors and anterolateral corridors. And the last is endoscopic intranasal approach. This day, an operative strategy is suggesting that provides a shortest and adequate routes, minimal or even no brain retraction, optimum visualization and multidirectional view, avoid a crossing important neurovascular structure, also interrupts the vascular supply of the tumor earlier. So the surgical strategy and plan. I can describe the tumor location divided into two groups, which is in the first picture you can see here, the tumor is in front of neurovascular structure, so only the back part of the tumor attached to important structure of the neurovascular, and also the second one is tumor beneath or inside the dome of neurovascular section, like this picture. So we have to know the blood supply of the meningioma itself, because this is a meningioma surgery. We suggest to cut off the feeder before we take out all the tumor to prevent the further bleeding. So as the anatomical, we can see here the anterior artery, posterior artery, often feeding of the tumor, and also anterior and posterior or basal meningeal artery as a mecanal capsular artery here. Imaging, correct diagnosis and management require an appreciation of the unique clinical neuroimaging and surgery-related feature. So the best imaging that we can have, I think, is very best, and also make it easier to imaging where exactly the tumor was. So the first one is anterior corridor, subfrontal unilateral or bilateral transversal or anterior interspheric approach. The unilateral or bilateral subfrontal approach was often selected. The advantage of this approach is that it provides a wide and direct view of the tumor and also both optic nerve, the ICA and the anterocerebral artery, posteriorly median pectoral stalk, and even complex basilar artery in the end. What to expect? If you can see in the picture, after we make the approach, we divided the brain from the medial part, and we can see here the normal anatomical view after we retract both brain, left and the right. You can see optic nerve, the optic chiasm, and also basilar artery here, and then the pituitary stalk beneath the optic nerve. So this is a surgery case. You can see we do the bifrontal approach for tuberculous meningioma. This is the case. The tumor on the sella is not quite a big tumor. After opening the bone, we try to dissect and retract the brain, both to the lateral from below, and now we can find the abnormal of the tissue, such as tumor, and try to remove it, debulking small part of the tumor. Try to find the lateral border of the tumor and try to dissect the attach the tumor from the normal tissue, such as in this video, the attachment to the right optic nerve. After find the normal capsule of the tumor and remove piece by piece, try to debulk the tumor until the last part of the tumor, and also coagulated the attachment tumor to the base of the dura. This is the last view after tumor removal. You can see here the optic nerve, optic chiasm, and also pituitary stalk. This is the post-op CT scan after surgery. And the second is paternal. This is the classic anterolateral approach. We already know all about this approach. What to expect after retracting of the brain from the right view of the surgery. We can see the optic nerve, the carotid artery, and the complex of anterior carotid and middle carotid artery. This is a surgery case. The female, 30 years old, with tuberculum cella meningioma. As you can see here in the imaging, the tuberculum cella meningioma is not quite big also, the tumor. We do lateral supraorbital approach. This is the position and incision. After opening the skin, make a skin flap, exposing of the bone. After opening the bone, we open the dura. After opening the dura, try to dissect the brain very carefully. Try to find the abnormal tissue. As you can see here, the tumor beneath the optic nerve, the right optic nerve. And also explore the lateral side of the optic nerve, which is the carotid artery of the right side. Try to dissect the attachment tumor from the optic nerve and the vascular, the carotid artery, and also the contralateral side of the optic. Try to dissect the border of the tumor. After that, try to remove it piece by piece. Debulk the tumor very carefully. And remove all the tumor and make sure there's no injury of the normal neurovascular structure. Supraorbital keyhole approach is minimally invasive approach, microscopic and endoscopic or combined, and also cosmetic satisfied for the patient. So what to expect? We can through the anterior skull base region through this kind of view for the approach. This is from sagittal view. As we can see, if the tumor all in the anterior skull base, we can see through this approach. If we found the tumor is more or less in the tuberculum cella area, we have some difficulty to reach this part of the tumor. What to expect after the opening? This is the anatomical view for the approach. This is the left side, this is for the right side. We can see the opticocarotid window, inter optic window here. So this is the surgery case. This is the incision and the position of the surgery. We do the endoscopic. After retract the anterior of the brain, we see the abnormal tissue, which is a tumor. We try to find the normal anatomical optic nerve here. As you can see here, the left optic nerve, and try to find also laterally the carotid artery. After we found the normal tissue, try to dissect the tumor and remove the attachment for the normal tissue. And after that, try to remove the tumor piece by piece, small part of the tumor, very careful. Coagulated the attachment from the dura skull base. This is the lateral part, as you can see here, the attachment tumor from the carotid artery, the left carotid artery. Try to remove the tumor. This is the last part of the tumor we can pull out from the side of the attachment. This is the normal final view. of the approach, and this is the post-op head CT scan. Intranasal endoscopic approach is skull-based surgery concept. Nowadays is very famous approach because it's remove the bone, make retractorless brain, and make the tumor become convexity. It's also minimally invasive approach, and changing trend in neurosurgery approach also have several limitations. So what to expect? As we can see, the anatomical landmark from below, we can see this part before the removing of the bone. This is the planum sella from below, and also some part of frontal base from below. After removing the bone and dura, we can see this is the normal view of the optic nerve, the chiasm, and also the anterior complex of anterior cerebral artery. This case, after we threw the sphenoid sinus and opening the bone, we can see the dura. Opening the dura directly can find the tumor here. After opening the dura, try to dissect tumor from below. After coagulating some of attachment tumor to the dura mater, now we try to dissect very carefully the attachment of the tumor from the normal tissue. As you can see here, the vascular structure of anterior carotid communicating artery, anterior cerebral artery, right and left, and also the posterior part. We can see here the pituitary stalk and also optic nerve and optic chiasm. After removal the tumor very carefully, now become very clear the normal anatomy of the sella itself. And this is the last part of the tumor. We can take it out from the nose. This is the post-op imaging after surgery. So, surgical approach for the sella anterior skull-based meningioma must be individualized. Each of those variety approaches have some advantage, also disadvantage. Choosing the optimal surgical approach can play a significant role in maximizing the extent of resection and surgical outcome while minimizing the risk of potential complication. So this is some article paper we published in some journal. So the conclusion, anterolateral supraorbital approach is preferred for smaller tumor, anteriorly for chiasm, extend laterally beyond optic and carotid, not goes deep into the sellar region. The pteronal approach prefer in larger and extended unilaterally tumor. Anterior transversal bifrontal or interhemispheric approach suggested for midline large tumor, extended upward, lateral, and backward. Endoscopic endonasal may be the preferred approach in tumor without complicated addition to vital neurovascular, especially expanded to lateral part. Thank you for your attention.
Thank you very much, Dr. Roland. It's a really great presentation. So we'll go to the next speaker, Professor Ahmad Farid, who would like to present about the intratumoral heterogeneity in a high-grade glioma. He completed his medical school and residency in Pajajaran University. He got a PhD from Gunma University, as well as a postdoctoral fellow, and many clinical fellow has been done by Professor Farid. Please, time is yours, Professor Farid.
Thank you very much, Dr. Agung. So I will share my talk. It's, as we know, that we are facing a very clever cell that for the last 2 or 3 decades, there's no improvement, even so ever that any attempt to decreasing the mortality. So I will talk about high-grade glioma, that even if we know the pathologies that we are facing, the very malignant cells in their own, even in the same patient, they have different characteristics. So I will show you later on. This is how we have to, I encourage every one of us to collect your own sample, your patient sample, because I believe every knowledge that we share to the world about the pathologies, about the behavior, that's because our effort. Without us, they will not know anything about this cell. So don't give all your cell to pathologists. You have to keep it for yourself. You can learn your patient from that. We have several patient collection. We take our patient sample and we put it in our banking for further study. And we collect, up to now, we only have 6 of our very malignant primary cells. Then we make some characteristic. This is how we profiling each of our patient. We want to see whether all these markers, and we want to know even they have same diagnostic, but we know that even you treated the high-grade glioma, the result can very different for each patient. Some good, some will make headaches. So we try to profiling in a very personal of this patient. We try to make some marker. We take a double staining for CD133, as we know for cancer stem cell. That's it's a very small amount of the population, but somehow they can dying when you treat it with your drugs, but they are not dead. So we try to make some counting about those CD133. Plus, we also want to see a CD15, known as a neural stem cell, which is they can go very high expression. It means it's very mature, or if you cannot find it, then you're facing is a very difficult situation. So we make those, we divided the population, we mix it into at least 3 groups. The CD33 negative, that's highly very difficult to kill, and CD133 positive. In between, you will see if they have additional CD115. So this is our finding from our collection. We found in each of the patient that we have those several groups. If you see below some table that we show you in the very last, in the very left group, CD both negative, double negative, this is a very malignant one in glioblastoma. If you treat this one, then you find the guilty victim. But it's difficult because it's difficult to kill unless we know how to cut many signaling pathway. And in between, in 2 group, CD133 positive, both CD15 negative or positive. This is the moderate, the middle class group. And the clone that have very low malignancy is CD133 negative with 15 positive. It means there's many neural progenitor, but not cancer stem cell. We are facing the cell that have the property of stem cell. They have very good tools to survive. This is how we prove it, that the CD negative, double negative, they will act like neural stem cells. Glioma cell is an adherent cell. They will attach to the parenchyma. But if you want to test your cell, whether they have the potential of cancer stem cell, you have to put it into free medium. If they can floating, if they detach and they can float, this is a very malignant cell, because the float cell is very good cell to survive. For example, our blood cell, that's very good cell that they will live in no dimension. So if you can prove it, then you're facing a very difficult case. And this is how we talk for education, that we not only talk about cancer, we talk about cancer stem cell. And we also try to make some summary of our result. And I think this is one of our future. There's no silver bullets. You can treat one drug for every disease. It's impossible. So this is how we know our patient. This is your patient. Don't just give it to any other specialties. You have to know, you have to collect them, you have to decide it different from each patient. And I think that's all my talk. Thank you very much.
Thank you very much, Professor Farid. So we'll go to the next presenters. It will be Dr. Irwan Barlian. The title will be the modified transpetrosal approach for the resection of the large and giant petroclival meningioma, technical nuances and surgical experience. He completed his medical school from the Muhammadiyah University and residency from Erlangga University. Please, Dr. Irwan Barlian, the time is yours. Dr. Irwan, are you here?
Dr. Irwan still mute, Dr. Agung.
Okay, please unmute yourself. Halo, Mas Ibi. Mana Mas Ibi?
Sorry.
Okay, yeah.
HP-nya.
Yes, please.
Thank you for the opportunity. I already make a recording presentation. So please, the committee to show the recording video.
Okay, Doc. Please wait a second.
Suaranya nggak ada nih suaranya.
Even the recording also mute.
Suaranya nggak keluar panitia.
Is our experience in Erlangga University and Dr. Sutomo General Hospital, Surabaya. As we know that petroclival meningioma was arising from petroclival area, remains a devastating challenge. Location itself on the medial of the fifth cranial nerve, and originally from 2/3 of the clivus lateral to the midline at the level of the petroclival junction. Usually, this tumor will displace the brainstem and the basilar artery to the posterior and to the contralateral side. And if the tumor growing bigger, will be displaced also other cranial nerve, and also will extend to the internal auditory meatus, the jugular foramen, Meckel cave, Duralis canal, and the ipsilateral cavernous sinus. So many approaches performed by the expert surgeon with the benefit and the limitation itself. But this time we would like to introduce our experience about modified transpetrosal transsensorial approach. First, the position of the patient was the lateral back bend with the head flat to the floor with horseshoe skin incision like a combined petrosal approach. And then was mastoidectomy was performed with a cosmetic mastoidectomy. And we drill the mastoid air cell to the semicircular canal. You can see from the CT scan that after we open the semicircular canal, after we open the mastoid air cell, the semicircular canal is still intact. So you can see the corridor was quite wide. So we can see the middle fossa and also the posterior fossa with this kind of opening. We didn't cut the anterior petrosal. After that, durotomy or tentorial tonsillectomy. Dural incision was performed like to preserve the superior petrosal vein and superior petrosal sinus. So durotomy will be performed on the two different area. First on the retrosigmoid part, and then the second one in the subtemporal part. After that, we perform a cisternotomy. It's very important to perform the cisternotomy in the foramen of magna because we will cut the tentorium, so we need the brain very relaxed. Otherwise, we have to retract the brain too much. This is tentorium incision. So we open the hiatus of the tentorium by the cutting of the tentorium. The tentorium was cut on the parallel to the superior petrosal sinus, approximately 1.5 centimeter to the medial. Please be careful during the opening of the tentorium because it's very close to the fourth cranial nerve. After that, we perform the resection of the tumor just to the from the posterior fossa. This is a sample, the sample case. First, 42 years old female with a headache and the balance disturbance and left facial palsy and dysphagia. You can see the tumor quite big and it extends to the suprahiatus to the middle fossa. So this time we perform the approach before we perform embolization to the tumor, and then we cut the mastodectomy. After that, we perform a cisternotomy, and then we come to the tentorial cutting. You see the tentorium was cut, and then after that, we can perform the vascularization of the tumor in the first step of the operation, so we can control the bleeding. So after the bulking, we can mobilize the tumor from the vital structure. After maximal resection from the subtemporal, we come to the posterior fossa to perform resection from the posterior fossa using a retrosigmoid route with the same technique, the vascularization, the bulking, and the dissection. So we use intraoperative monitoring with this approach to monitor the cranial nerve. Our experience, we performed 26 cases from the last 5 years with the main age was 45 years old with female mostly of the female 4.5 with the clinical symptoms. Most of the cases was headache and the cranial nerve problem with the 7th nerve 42%, followed by 3rd nerve and the 5th nerve. The radiological finding, most of the cases was a big tumor, a giant tumor. Approximately maximum the diameter was 45.2 millimeter, with the extent to the inferior 22 cases to the 15 cases to the intraoperative internal auditory meatus, and the 7 cases also extend to the jugular foramen. So this is one of the benefit of this approach, because if we only perform anterior petrosal approach, it's very difficult to reach this inferior extension. And then the basilar artery was displaced to 73%, and then circumferentially encased 15%. And then the brainstem compression, most of the compression was a grade 3 because of the big tumor. And then all of the cases was extended to the middle fossa, to the suprahiatus. This is surgical outcome. 46% we perform gross total resection and subtotal was 54%. 61% was improved and persistent was 30% and mortality was 1 because of the infarct of the posterior cerebral artery and one of the liquor leakage but stopped by the lumbar drain. And permanent postoperative cranial nerve injury was 3 patients, 4 and 6 and 7 cranial nerve. This is the second cases, the female 45 years old with headache and tetraparesis. See, this is a multiple meningioma. We perform both of the tumor, but now we only, I want to show you the combined approach. So it's the same technique. We perform the decompression of the cistern of magna. After that, you can see that the brain is very relaxed. So we can easily retract the brain to see the tentorium, and then we can easily cut the tentorium. The bulking was performed and then dissection. Until the maximal resection of the supratentorial part, we perform the fossa posterior part. Use the same technique, the vascularization, the bulking, and dissection. So this is a post-operative patient. Now she already can drive a motorbike. The benefit of this approach was first early devascularization and detachment of the tumor, early decompression of the brainstem because of so we can decompress the brainstem in the beginning of the approach, so it's quite safe, and sufficient access to the supratentorial extension, preserving the superior petrosal vein and superior petrosal sinus, and simple petrosectomy drilling, low risk of liquor leakage because we don't drill the petrous apex and lumbar drain without lumbar drain, and of course we reduce operating time. You see, this is one of the benefit of this approach. We can preserve the superior petrosal vein. You see, this is post-operative view. Post-operative, you can see the superior petrosal vein is still intact. But this approach have many limitations, like high risk of trochlear nerve because we get the tentorium just next to the fourth cranial nerve, and difficult to access the cavernous sinus because of the we didn't cut the petrous apex, so we didn't open the Meckel cave, so it's very difficult to reach the cavernous part of the tumor, and the risk of injury of the vein of Labe because of we open the dura just next to the vein of Labe, just below the vein of Labe, and the drilling on the petrous apex is didn't perform, so we cannot open the Meckel cave. This is one of the pitfall case. 54 years old male. You can see this tumor quite big, but if we can see clearly, there is the tumor didn't extend to the suprahiatus. But this time we perform the same approach. So we have to carefully evaluate the MRI. It's the same approach. So we perform the sternotomy and then we cut the tentorium. You see, because of the tumor didn't extend to the tentorium, to the supratentorial, and also didn't have attachment to the tentorium. So after we opened the tentorium, we didn't see any tumor. So after that, we perform the same approach. We go to the to the posterior fossa and we perform the retrosigmoid approach, so we can resect the tumor like by the retrosigmoid route. So in this, with the same technique with the vascularization, the bulking, and dissection. So this is the last view of the tumor, so we can still perform the gross total removal. In the summary, minimal transpetrosal and tentorial approach is quite effective and safe approach to resect big petroclefal meningioma with dural attachment to the tentorium. Thank you so much for your attention. I hope this can give you a more information, more experience about this kind of approach. Thank you.
Thank you very much, Dr. Irwan Balian. So I think we're going to proceed to the last speakers. Dr. Julius Julai, he's my senior in Pajajaran University. He completed his medical school from North Sumatra University and PhD from Hasanuddin University. He will talk about the single nostril endoscopic transperineal for pituitary tumors, result and complication. I know he's a very expert on it. Please, Dr. Julius.
Thank you, Chairman, Dr. Agung. I have pre-recorded versions, so I already sent to the committee. Thank you. Hello, everyone. First of all, I would like to say thank you and congratulations to the President of the second ACNS International Virtual Conference, Dr. Rohadi, and all the committee and team. Today, I'm going to talk about the single nostril endoscopic transperineal surgery for pituitary adenoma. So since early 2008, this surgical approach has become a routine approach in our institution for pituitary tumor. And we collect 512 cases for the first 9 years, and all done through single nostril, majority through the right side. And then we evaluate the result and complications. If you look at the characteristic of the presentations, majority of patients presents with visual field constrictions in combinations between the apoplexy and non-apoplexy one. And cavernous sinus consists of 3.1%, and 14 of them it's purely apoplexy, and 2 due to the infections that coincidence happened with this pituitary adenoma. And 16% presents with mild headache and history of headache. And for 1.4% presents with hyponatremia that require multiple admissions to hospital. And only a small number that functional adenoma. So if you look at specifically for pituitary apoplexy, if you take a look, very often from the history taking, we know that the patients have a history of headache. And not every one of them presented with acute visual deterioration. And sometimes, if you take a look at the cavernous sinus syndromes, 14 of patients with pituitary apoplexy also presents with cavernous sinus syndromes. And you can see that this case very obvious that when we ask the patients to see and look at the right side, and then we can see that third nerve palsy and also 6 and specific feature of the T2 MRI shows that apoplexy in the tumor. And also size and here is not really important. And then it's more important the acute expansions and also whether there is a coincidence with mucosal infections. There's a component of infections that causing cavernous sinus syndrome. This is a picture after surgery. You can see that the tumor is gone and then the patients recover. If you take a look at the two cases that we have presented with cavernosinus syndromes that have infections, we know that this is one of this case. We presented this T1 with contrast, ugly looking at the squamous sinus, and it's full of infections. So this is coincident with infected mucosals. And patient presented with ptosis on the left side. Whether we gonna do it with single step or two step, it's still controversial. I think in our institutions we prefer to do it in one step, as long as we can be make sure that we don't cause any CSF leak, because there will be a chance for infections to ascending to intracranial. This is another case that we take a look at the T1s without contrast. And lower part, we see this hyperintensity consistent with the mucosal infections. And when we put a contrast in, and we see the tumor part also enhanced. We have two cases that came with sudden deteriorations until blind from the apoplexy. As you can see this case, the T2, sorry, is T2 with fluid levels. You can see that this is before contrast, and this is after contrast. And this case, the surgery done within 30 hours, and then this is before surgery, and this side after surgery. Even after we remove the tumor and prove that there is no compressions, and from the blindness, it's improved to some degree of visual field, but it never come back to the normal visual field. I think it's because of the acute and sudden expansions of the tumor itself because of the apoplexy. But these patients can function well. He can drive and breathe. If you look at the proportions of the functional adenoma, very rare we need to do for prolactinoma, as long as they respond with medications. But some patients cannot tolerate the medications or not respond to the medication, so we have to do the surgery for them. In a small size of prolactinoma, before we put the patients on the medications, we usually offer them the surgery, because if the tumor is very still small, and we know that there is a high chance for them to be cured with surgery, and then we will offer them surgery. For Cushing disease, we have 5 cases. I think diagnosis for Cushing disease in Indonesia, I think it's still under diagnosis. Because diagnosis for Cushing disease is, I think, a bit challenging. First, we have to prove this is a Cushing syndrome. Consists of collections of 24-hour cortisol in urine, and also low-dose dexamethasone suppression test. And after that, we have to rule out whether differentiate between ACTS dependent or non-ACTS dependent. And once we develop diagnosed with ACTS dependent, and then we have to rule out the extra pituitary ACTS source. And then after that, we need to do thin slices of the MRI to prove that there is a lesions that we're aiming for the surgery itself. If we cannot find the lesions through the dynamic MRI, we need to step up to the transverse sinus blood sampling to check for the ACTS level, so we can decide which side we need to do the hypophysectomy. I think Cushing disease is a fatal disease if we don't treat it well, because it happens majority young age, and they usually have inappropriate fat pack disposition, like in this young lady, buffalo hump. And look at the neck, a lot of fat, thin skin, easy to bruise, and can see hirsutism in this case. As you can see that striae, this is the MRI. You can see that this is lesions. And sometimes they have a lot of pimple, so, and moon phases. So the patients complain about that and looking for help. And then when we arrive at the diagnosis, we can do the surgery for them. After the surgery, very important, the next day, early morning post-op cortisols have to be low. That's confirms that we get the tumor out. So this is the case after the surgery. The next day, 1.8 micrograms. And then during follow-up 3 months, it's come up slightly to the normal range. This is another case that we can see that thin skin, striae, bruising, and then moon phases, and you can see that hypointensity of the tumor in the middle. If we take a look at the acromegaly, we have 10 cases. Acromegaly involved with the skeletal overgrowth. Sometimes they have difficulty breathe during sleeping due to their large tongue. And then they have usually hypertension, peripheral nerve entrapment, headache, arthropathy, and also glucose intolerance. And dynamic MRI is very useful to differentiate the lesions from the other part of the pituitary. As you can see the picture here, frontal bruising is one of the feature. The jaw is big, and then if you look at the hand, finger, and toe, it's very obvious. If we look at the imaging, there's a huge variations of imaging. Sometimes it's very classic. You can see this one, and sometimes they have expansions to downward, upward, to lateral side, and sometimes they have a cystic formation inside, portions with apoplexy, and sometimes they have a cystic formations, like in this case to the temporal side. Very often we see flip filter level. It's about 10% of the cases. If we take careful analysis and history taking, they have a previous history of headache. For surgeons, and sometimes we need to estimate or we need to predict whether the tumor is hard or soft. One of the key features that I use is T2 MRI. As you can see, this feature is very specific. There is a lot of small cyst degeneration inside the tumor. This is a typical feature of a soft tumor. And this is another case, and you can see that this feature also happened here. And then the contrast MRI usually have a patchy appearance of this hyperintensity inside the tumor. This is also another feature. And then on T2 MRI without contrast, you can see that the water content inside the tumor is prominent. Sometimes we also need to see the T1 with contrast. We can imagine that there is a pseudosepta inside the tumors. It's like pseudocapsule inside. The useful of understanding is that when we curate this thing, sometimes we thought that we already arrived at the diaphragma cell, but we know that it's probably not yet, because this septa can be touched like a membrane as well. And if you look at the middle picture, we see that there is a lot of fiber-like structure inside the tumor, and there is a cystic degeneration on top of that. Although this tumor is soft, we know that we need times to just a little bit longer and slightly difficult to get out all this fiber from the attachment to the wall. And this is also another example on the right side as well, that the fiber. Dural tail is not specific for meningioma. So any tumors that have angiogenesis can present with dural tail, including adenoma and also acoustic as well. So in this case, we need to see that this is adenoma, and then there is a dural tails. This is after surgery. This is 1 year after that. Sometimes we have a complex case like this with feature of the another lesions, ABM, on top of this pituitary adenoma. Although if you take a look at the T2 MRI, a lot of water content, we know that this is going to be soft tumor, but be careful because of the angiogenesis, could be a lot of bleeding, a lot of blood. Sometimes we have a case that rarely presents with multiple lesions, multiple primary tumor like this one. He presented with glioma, presented as Caesar, but he also has this pituitary and the acoustic. In terms of surgical positions, we do it very simple, just flat and neutral position. Always prep the abdomen in case we need a fat graft, and using a very simple instrument, rigid endoscope. We use a rigid endoscope, 18 centimeter, 0 degree. Sometimes we need to use neuronavigations if the pneumatizations of the sphenoid sinus is not very good. So we need navigations to avoid us getting lost to the side, so endanger the IC. Sometimes we need also intraoperative doctor to check for the IC. In terms of nose preparations, for sure, I always use the adrenaline plages to shrinkage the turbinate. And then once we shrinkage turbinate, we have the space and aiming to the sphenoid media recess, coagulate as necessary, and then start to drill. Opening is just as wide as necessary. It's unnecessary to do so wide exposure. It's kind of to preserve the mucosa, surrounding mucosa as much as we can. But the opening have to be enough so the maneuver of the surgical will allow us to move freely inside and not having the insulin fighting inside. So this is on the right side, you can see that using a ronger, we widen the opening of the cellar floor, opening the cellar diaphragm dura using the telescopic knife and starting the systematic curette. And very often I use a falsifier maneuver to push the diaphragm down. And then at this end, after we remove everything, every tumor, every piece out, and then the diaphragm cellar will come down and make a tamponade so the bleed will stop. If you look at the result, a visual improvement 3 months by ophthalmologists, we achieve at 89%, which is quite satisfied. In terms of resections, less than 3 months, we achieve 82%. But if we follow them long enough, and then after 6 months, we see that the extent of resections is actually increased. This may be due to degenerations of the part of the tumor, the residual tumor that left behind. Such as in this case, we know that we left some tumor behind on the top of the superior anterior side. And after 8 months, we see that it's gone because of the degeneration. In terms of length of stay, more and more, we now have patients stay just for 1 to 2 days after surgery. Very rare they require ICU observations. And this is one of the examples for follow-up. This is prior surgery, after surgery immediately. Sometimes we offer the patients, if patients want the MRI, and immediately, but it is not regularly done. After 3 months, and then we do the MRI for the baseline, and then after that, once a year for the follow-up. So this is a kindly classic picture that we have after the surgery. Subtotal removal, sometimes we have a tumor left behind, especially at the superior anterior side, like in this case, and then we just observe the patients. Involvement with cavernosinus, we tend to be not so aggressive, and then we just tend to be observed. Second surgery for regrowth tumors, we have actually residual tumor for 59 cases in total. But it's only 27 cases that regrow tumor, 25 from the residuals, obviously, and then 2 cases that initially we considered it total removal and clean, and then 1 recurrent at 2nd year, and the second one is recurrent at 3rd years. So that both require residual second surgery. 15 case that during follow-up we sent to the gamma knife, but eventually because of the visual impairment, after that during follow-up we have to redo the surgery for them. In terms of complications, we have CSF flare, which is not big number, mild headache, mild DI, carcosmia treated with antibiotic for it usually happen at second week, treated with antibiotic. And we have I have one carotid injury. This is case number 5 in my career. I think what we have learned is actually, if you look at the tumor that extend to downwards, so we have to be careful because of the erosions from the tumor can make this carotid artery actually exposed. And then using grabs in the blind spot, I think is very dangerous, and then can grabs and tear the carotid wall, such as in this case. So this luckily I can control the bleed with small balloon Foley catheters, and then as the colleague from the cardiologist at the time in 2008 to put 2 stents, and then we saved the patients. At that time, we don't have colleague that develop the endovascular yet, but nowadays we have a colleague that can do endovascular. Post-operative hematoma usually happen for redo cases, and then usually due to the fat graft that causing fibrosis around that. So I don't really favor using a fat graft. In my career, I think I use fat graft less than 10%. Delay epistaxis usually because of too dry. And second nerve injury, I have 2 cases actually slightly get worse, but during operations, I don't see any CSF leak for these 2 cases, and the MRI show quite reasonable result, but still 2 cases with slightly declined visual field. I have 1 case with meningitis, they require 10 days hospital, and 2 cases with pneumocephalus post-op, and MTCLA syndrome, 1 cases that developed 6 months after surgery. As we can see, this pituitary, the cellular floor is not very big, but it's still, you can see that the second nerve actually sink to inside the MTCLA. You can see that the kinking of the second nerve here. In terms of olfactory functions, based on post-operative history taking in clinic, 74% able to smell. So it's a quite satisfying number. Average olfactory recovery, I would say 6 months, only few cases that require under 3 to 4 months. If we compare the results with other study that doing comparison between mononostril and binostril, you can see that the obvious thing that we can see is operating time. I think a mononostril saves slightly at least 15 to 20 minutes compared to the binostril. And in terms of the surgical result, I think it's comparable between these 2, including the visual improvement, which is comparable, and also the complications also comparable between these 2 approaches. So in conclusion, I would say if both approach comparables can be obtained with mononostril approach, so if comparable outcome can be approached, can be achieved with mononostril approach, I think mononostril approach should be considered and further investigated as the first line technique for majority of pituitary adenoma. It is unnecessary to directly doing binostril. So in the beginning, we just can do mononostril. If that's enough, I think we don't need to do binostril. But during the time we do the uninostril or mononostril, in certain cases that require more room and more exposure, and we can easily convert it to binostril. But we need to be appropriately selected based on the size of the tumor. And also, we need to improve our expertise in expected tumor consistency based on the MRI feature, as I mentioned before. So we can actually predict what kind of tumor is actually better we do with melanostrate. And also the extent of invasiveness into a nearby structure. I think it's also will give us a good informed consent and information to the family, whether we can do it in combined approach or in one state or two states approach. And thank you very much. All these data have been published recently in clinical neurology and neurosurgery. So it's in more details you can read in this particular report. Thank you very much.
Thank you very much, Dr. Julius. Exactly, we get on time on this session. So I think we still have 10 minutes for Q&A, but there are several questions on the chat. We can read. The first question will be to Dr. Renendra. Thank you for excellent presentation. What do you think about the idea to do decompression of optic canal for the SOM to improve the visual acuity? The question from Dr. Doni. Please, Dr. Renendra.
Thank you, Dr. Agung. Thank you, Dr. Doni, for the question. As you know, when we have hyperostosis, then the bone is not normal anymore. So the first strategy is that we resect all the hyperostosis. We structure of the superior orbital fissure and also the optic canal by do more drilling with microscope dissection, and you can dissect or drill the ACP, which is the anterior clinoid process, and decompress the optic foramen from there. So first of all, of course, you have to do the drilling of the hyperostosis to get a better view. Thank you for the question.
Thank you, Dr. Renendra. So the next question coming from Dr. Stephen to Dr. Rahadian. Thank you for the presentation. He's asking about, may you give us the advice or a clue to identify the asterion? And then the second question is how we resect the tumor inside the IAC, especially the dumbbell-shaped vestibular schwannoma. Please, Dr. Rahadian.
Okay, thank you, Dr. Agung. Dr. Stephen, thank you for the question. For the first question, we can identify asterion by identify the squama temporalis and lambdoid squama, and the mastoid squam, and then the junction between three squama is 60% is the asterion. We must remember that 60% asterion is just above the sinus, so we must carefully do the perforator. Make sure that you have sharp perforator that make you put a little force during drilling. And then how to resect the tumor intra-acoustic canal, especially in the giant vestibular schwannoma. Usually the canal already enlarged, so it's also answered the Dr. Doni question. I didn't drill the intra-acoustic canal in the giant acoustic schwannoma because the canal already enlarged. Yeah, so we can resect the tumor without opening, without drilling it. But if you find some bone extrusion, you can easily cut it without difficulty. Okay. Thank you, Dr. Agung.
Thank you, Dr. Rahadian. And then the next question to Dr. Rahadian also from Dr. Doni. Is asking about how to use the IOM, but if they don't have intraoperative monitoring, what do you have suggestion? And then the other one is because often make us stop during surgery early. Why you don't routinely opening the IOM for giant swanoma? Please, Dr. Hadian.
Okay, thank you. The last question I already answered. About EOM, there are a NIM system by Medtronic. That's very simple thing that maybe Dr. Agung know that we use it in Japan, that it can be operated by neurosurgeon. It's only a stimulator for facial nerve stimulation only. As you know that we have several procedures that can be used for facial nerve evaluation. If using NIMS, you only can use for mapping using trigger EMG in the facial nerve. But if you could in EOM machine and have good neurophysiologist, you can use train. Is running EMG. Train is very tricky because the neurophysiologist must watch the wave during your dissection because the train is very short. There's several kind of train, and it is need a good neurophysiologist. The third one is using TCMEP, transcortical motor evoked potential. They stimulate in the scalp, and we record the wave in the periphery. It can be used for continuous evaluation. Once again, it needs good neurophysiologists. To avoid stopping too early, we must have good anatomical orientation. So the EOM is helping us. So it's very important for the surgeon to identify the structural anatomical structure. The second is you must use appropriate power, milliampere. Usually, if for screening you use 2 milliampere, but if you are already close to the nerve, you decrease the stimulator to 0.2 or 0.1 millimeter. If in the 0.1 or 0.2 still contraction, it means the nerve is very close. But if you put in 2 millimeter, it's still far away from the nerve itself. So don't stop if the stimulator still in the 2 millimeter. Stop if it's in 0.1 or 0.2. And try to track the nerve from the internal acoustic canal. If you disoriented, go to the canal and track to the nerve from the canal. Maybe Dr. Agung can add the trick during this section. Dr. Ohira teach me about that tips. Thank you.
Okay, I think it's already answered by Dr. Hadian. Yeah, silakan Dok.
Yeah. Regarding the opening of the optic canal of the meatus, internal meatus, I think that this is I always open this, although that this canal has been so big, because we can start removing the tumor entirely from the normal nerve. So make sure that you have reached the normal nerve, and then you down to dissect the tumor. So, and in my opinion, that's not possible to not to open the internal meatal, just remove the tumor or pull out the tumor without making sure that you have already reached the normal nerve. Reaching the normal nerve is that we have to open the internal meatal. I do this routinely. I always open this. It's not difficult to open this. I think if the big tumor, after removing a partial of the tumor, and then we can go to the optic canal to make sure that we can see at least the normal nerve. Otherwise, if we move from subarachnoid space and then we lost. We have to work in this what we call it from this not from the arachnoid space, because if arachnoid space, we follow the arachnoid space and then we will injure the nerve. So I always work from inside, from the meatus and down. That the way of having a total remover, if possible, especially for the solid tumor. In cystic tumor, sometimes it has a very strong adherence to the brainstem or to the nerve. That's my comment.
Thank you,
Thank
Dr.
you.
Golden.
Thank you, Dr. Golden. It's very valuable comments. Just short comment from me. Usually I measure the depth of the internal acoustic canal from the CT scan or MRI. If it is length about 7 to 9 millimeters, and we use the 3 millimeters diamond burr hole, you can make a 3 burr holes and a posterior part of the wall of the internal acoustic canal. Then you can find and open it very easily. I think. And the last question to Dr. Roland, even already answered by chatting. Maybe Dr. Roland have any comments or?
Yeah, thank you. I already answered by chatting, Dr. Agung, but if there's any time. Yeah, in my learning curve experience, Dr. Doni, thank you for the question. I just start this kind of technique from below 5 or 6 years ago. Small number experience, but if I have a small tuberculum cell meningioma and is in the midline side and also not too laterally involving so much ICA, I think is, in my opinion, is good candidate approach from the below to endonasal endoscopic, because if we work from below, so we directly facing the tumor and then try to dissect the tumor without, and we avoid this normal structure. I'm very sure Dr. Doni also already done the technique between the endonasal and supraorbital approach. So I mean, you also agree with me, if the tumor much in the curve of the cella, if we go through from the supraorbita, maybe we have some little bit difficulty view, because we block the view of the surgery can block by a pladum cella. And if we do from the supraorbital approach, so we have dealing with the normal neurovascular first before we can reach the tumor. That I hope you got my point. That's my answer, Dr. Agung.
Thank you, Dr. Roland. So we just finished our session. Thank you for all participants and speakers. This is very nice, and I think you're getting more specific and much more subspecialty in skull-base surgery and also oncology. Thank you for all, and I will give the time to the committee. Thank you very much.
Thank you, Dr. Agung, Dr. Hadian, Dr. Golden, Dr. Renindra, Dr.
Thank
Julius.
you.
Thank you so
Well
much.
done.
Thank you, everybody.
Thank
Excellent.
you, everybody.
Thank you all. Professor Farid, thank you.
Yeah.
Be healthy,
you.
everyone.
Stay safe.
Stay safe.
Do not get infected by
Get
COVID-19.
vaccine. Get vaccine, sir.
Get vaccine, yes.
Third
Do not
vaccine
get
is very
infected.
important. Third vaccine.
See you next time, Dr. Golden.
Yeah, yes.
Yeah.
Thank you.
Okay, thank you
See
semuanya.
you.
Bye.
Bye-bye.
Okay, bye.
Bye-bye.
Bye, everybody.
Bye.
Ya, Dr. Ibi itu.
Okay,
Bye.
thank you for all the participants of the skull-base second session. The session is over now, and then there is no other session of skull-base for today. So if you're interested, you can join us on another session. We still have vascular third session on the link. You can check it on the website. And then we still have other session too from Young Neurosurgeon 5 and Young Neurosurgeon 2. You can log into the session on the website. Please do check our website for the session. Thank you.
Izin live ya, Mas.
Oke, terima kasih Dokter Hadian.
Ini nggak ada, setelah ini habis, setelah ini ya harus pindah, harus keluar berarti.
Oke, di sesi ini sudah habis dokter.
Oke, terima kasih ya.
Oke, terima kasih banyak dokter.
Assalamualaikum.
Waalaikumsalam.
Bentar.
Tutup aja deh. Tutup aja sesi.